Alrighty, here we go. Hello, and thank you for watching this program on diagnosing radiculopathy. There's no audio taping or videotaping allowed, and any unauthorized reproduction, dispensing, forwarding, or copying of this target coding presentation is illegal. The information in this presentation is for educational purposes. It's not intended to substitute your thorough clinical decision making. Target coding is not a law firm. We don't engage in providing legal services. CPT is a registered trademark of the AMA. Every attempt has been made to make certain that the information in this presentation is 100% accurate. However, it's not guaranteed. Just a little bit about myself before we get started. My name is Dr. Marty Kotler. I am a chiropractor. I'm certified in CPT coding. I'm a certified professional compliance officer. My areas of expertise include CPT and ICD-10 coding, Medicare compliance, HIPAA compliance, record keeping, compliant treatment plans, compliant cash plans. I've written many training manuals on billing, coding, compliance, and documentation. I write articles for Chiropractic Economics, Dynamic Chiropractic, and many other newsletters across the country. I'm also a guest speaker at many state association conventions. So let's begin with radiculopathy. Let's go over some of the key points regarding radiculopathy. Radiculopathies are very common in chiropractic settings. Radiculopathy is a compression or irritation of the nerves as they exit the spinal column. So common symptoms include arm and leg pain, numbness, tingling, weakness in the legs or arms. Many patients seek out chiropractic care for radiculopathy type of conditions and respond very well to chiropractic care. Now, radiculopathy can occur in any part of the spine, but it's most common in the lumbar and cervical, and that's where we're going to be focusing on today, cervical and lumbar radiculopathies. Radiculopathy, nerve root compression, can be caused by many things. Spurs, osteoarthritis, herniated discs, bulge discs, protruded discs, extruded discs. So how do you diagnose a patient with a radiculopathy? You always want to code to the highest degree of specificity. So you don't want to diagnose a patient with a radicular type of condition if they don't have it. So it all begins with a thorough history and exam. In order for your services to be considered reasonable and justifiable, health plans, your state scope of practice laws, and standard practice acts require that your diagnoses have validity and they can link with your procedure codes and they're substantiated in your documentation. We're going to go over a little bit later how to pair your diagnosis codes of radiculopathy with certain procedure codes. The clinical rationale for choosing a diagnosis must be in writing. It must be part of your plan of care and be in the patient documentation. Now, with radicular type pains, MRIs, NCVs, EMGs, other diagnostic tests may be indicated. For some of the diagnosis codes that I'm going to share with you today, if you do not do an advanced diagnostic test, it's hard to prove that that condition actually exists. We're going to go over a few of those later. So let's begin with a few. Some of the more common ones. These are ICD-10 codes that have disc disorder with radiculopathy in the description. So the first one, M50.1, cervical disc disorder with radiculopathy. I don't recommend you use that one. It's not specific enough. In the cervical region, ICD-10 codes offer very specific levels. So you always want to code to the highest degree of specificity. If a patient has a herniated disc with radiculopathy at C5, C6, you're not going to use M50.1. I don't recommend you ever use M50.10. There's a chance that code would get kicked back as being invalid or not substantiated. M50.11, that's a good one. Cervical disc disorder with radiculopathy. high cervical region or at C2, C3, C3, C4. Why not C1, C2? Well, there's no disc between C1, C2. M50.12, stay away from that one. In general, although it exists and it's a valid diagnosis, it's in the ICD-10 tabular list, the global list, I don't recommend it be used because it just says mid-cervical. It's not specific enough. I've seen providers get that code kicked back. So if it's going to be a cervical disc disorder with radiculopathy, at C4, C5, go with M50.121. At C5, C6, that's M50.122. Probably the most common one out of all of them, C5, C6, at least in my practice. That's where I found the most disc issues between C5 and C6. M50.123 is cervical disc disorder with radiculopathy at C6, C7. And then we have M50.13, cervical disc disorder with radiculopathy at C7, T1. That's the cervicothoracic junction. Let's take a look at the thoracic region. So we have disc disorder with radiculopathy in the thoracic region. That's M51.14. Thoracolumbar junction, M51.15. Lumbar radiculopathy with disc disorder is M51.16. Wait a second, how come we don't have one at L1, L2, L2, L3, L3, L4, L4, L5? Doesn't exist. We have the specific bones in the cervical region. ICD-10 does not include specific bones for disc disorder with radiculopathy in the thoracic or lumbar region. Why? I'm not sure. I thought there would be an update coming up with the next round of ICD-10 codes, but there were no updates to these specific codes, so we are going to need to use these for the next year until the following October. And then we have M51.17, disc disorder with radiculopathy at the lumbosacral junction. Now, these codes here, these are radiculopathy codes, but there's no disc disorder involved. There's no specific disc levels mentioned here. So these are a little different. The previous codes, disc disorder, meant that there was some sort of herniation, bulge. We're going to go over the differences between disc disorder and disc displacement in a few minutes, but a disc disorder would indicate that there's some sort of herniation, bulge, protrusion. With these radiculopathy codes you see on your screen, you don't necessarily have to order or have an MRI to back it up or a CT scan. So let's look at the first one, M54.10, radiculopathy, site unspecified. I recommend you stay away from unspecified codes. Now, there are a few things here that I'm giving you my clinical opinion. So there are certain parts of this presentation where I'm taking off my coding and compliance hat. I'm taking off my expertise in coding hat, and I'm putting on my clinical hat. When I put on my clinical hat, understand that I am not the clinical guru. I am the code guru and coding and compliance expert. But when it comes to clinical, I'm just giving you my opinion. So that's a question I often get. Dr. Kotler, if the patient has, if I'm going to use a radiculopathy diagnosis, do I have to have an MRI? In my opinion, no. But with the disc disorder, and you'll see coming up disc displacement codes, in my opinion, again, putting on my clinical hat, yes, you would need an MRI or a CT scan. So for these that you see on your screen, these would have to come from your history, examination, and your thorough clinical approach. So next, M54.11, that's radiculopathy at the occipito-atlantoaxial junction. M54.12, cervical radiculopathy, that's a pretty common one. 0.13, cervicothoracic. M54.14, thoracic radiculopathy. 0.15, thoracolumbar. M54.16, lumbar radiculopathy, that's very common one that's used. M54.17, lumbosacral radiculopathy. And then we have radiculopathy all the way down at the sacrum and sacrococcygeal junction. That's M54.18. Okay, so here we go with the cervical disc disorder with radiculopathy. So again, radiculopathy means that there's some sort of nerve root compression, which is causing pain to radiate down, in this case, cervical disc disorder, down an arm. So example, M51.122 would be herniated discs, bulge disc, extruded disc. That's causing nerve root compression at the C5-C6 junction. Now we have another set of codes. This one says cervical disc displacement. Wait a second. Disc displacement, what's the difference between a disc displacement and a disc disorder? That's a very common question that is asked. So we have a whole bunch of codes here that say cervical disc displacement without radiculopathy. That's the key right there, without myelopathy. So what's the difference between a disc disorder and disc displacement? Many of the doctors that I speak to and staff members, they're not sure what the difference is between disc disorder and disc displacement. So let's go over that. A disc disorder means that there is some sort of disc pathology, bulge, herniation, with nerve root compression. Disc displacement, that's different. Also disc involvement, disc pathology like a herniation, bulge, but there is no nerve root compression. That's not uncommon. I would have patients come in and say, hey, Dr. Kotler, I have lower back pain. Okay. How long has it been going on? It's been going on for years. On and off for years. It's a chronic problem. Do you have any pain radiating down into your legs? No, it is localized to my lower back. I got an MRI recently. Here's my MRI. It shows herniated disc at L4, L5. So that would be disc displacement. This patient doesn't have any compression. There's no radiculopathy. The MRI might say without myelopathy. That's another common term. And that's another common item I'd like to clarify here, because I get this question all the time. What's the difference between radiculitis, radiculopathy, and myelopathy? So radiculitis is inflammation of the nerve root. Radiculopathy is that radiating pain. And myelopathy means there's cord compression. So when I review my clients' charts, every once in a while I'll come across a provider, one of my clients will diagnose a patient that says cervical disc disorder with myelopathy or lumbar disc with myelopathy, and I typically will contact the provider. And most of the time the provider does know what myelopathy is, but every once in a while I'll get a client that says, oh, Marty, no, myelopathy, that's cord compression. I didn't know that. I did not choose the right diagnosis. So if you're going to use a diagnosis that says with myelopathy, you're going to need an MRI. Again, I'm putting on my clinical hat. You're going to need an MRI or a CT scan to justify that. So careful with myelopathy. Understand what these terms mean so you are choosing the correct diagnosis codes. Okay, now we have other types of radiculopathy here under the sciatic category. So sciatica, M54.13. I don't recommend you use that. If you're creating like a cheat sheet, I'll show you an example of an ICD-10 code cheat sheet I created. If you're creating a cheat sheet, a favorite list, whatever you want to call your pick list, don't include M54.3. Even though that says sciatica, it's not specific enough. M54.30, sciatica unspecified, that would probably get kicked back. Now, why would you even have to use sciatica unspecified? I can give you an example. Hopefully it never happens to you. So Mrs. Evans comes in. She says that she has pain radiating down the leg, and you don't ask her which side. She doesn't write down which side. Now she leaves the office. You're about to submit the claim. Your notes don't say right side, left side sciatica, so you don't know which side it is. That means your notes cannot justify it. You would need to diagnose with code M54.30. But again, that would probably not get processed properly. And if you have, if you're using an electronic or a clearinghouse, they would probably stop it there and not even allow you to get it to the plan. So now we have a little laterality here. Sciatica right side, M54.31. The number 1 designates right side. Number 2, left side. So sciatica on the left side is M54.32. What about bilateral sciatica? Is there a diagnosis code for bilateral sciatica? Another common question I get, and the answer is no. There isn't. We don't have one for bilateral sciatica at the present time. Now we have a combination code here in ICD-10, one of these rare instances where they combined 2 codes. Remember, back in the day with the ICD-9, well, back to sciatica on the right or the left, it was the same code, 724.3. It didn't matter if it was right side or left side. So we have some laterality and specificity here with ICD-10. There are some codes in ICD-10 which I don't understand why they were kept vague and general, and then many of them are very specific. That's one of the things about ICD-10 for most codes. It got very specific. This way, it is causing doctors to have to justify the codes more than in the past. But back in ICD-9, we had sciatica, and it didn't matter. It was the same code, right side or left side. And then back in ICD-9, if the patient had low back pain and sciatica, we had to submit 2 codes. Low back pain was 724.2. Sciatica 724.3. Forget about those. Those days are over. Now we have a combo code, low back pain with sciatica, all in one code. It's M54.4. However, don't use that. It's not specific enough. So, low back pain with sciatica, right side, go with M54.41. Low back pain with sciatica, left side, M54.42. Now, I mentioned justifying your ICD-10 codes. That's where ICD-10 knowledge and justification has been kicked up a notch. It's caused for some providers to go down a new road because they're not used to this level of justification. Let me give you an example of what I'm referring to. So let's say you diagnose a patient with sacroiliac sprain. That's S33.6. Sprain codes begin with the letter S. So we have S33.6 for sacroiliac sprain. But, any type of sacroiliac joint issue, pretty common in chiropractic. Patients will have pain in the SI joint, maybe sacroiliitis, sacroiliac subluxation, or sacroiliac sprain. So let's say you diagnose a patient with sacroiliac sprain. You submit the claim to the carrier, and then you have an insurance company now is questioning you. Maybe a health plan that you're in network with has a case reviewer that contacts you and says, hey, Dr. Kotler, we see that you diagnosed a patient with a sacroiliac sprain. Can you explain to me, how did you come up with that? So if you're ever contacted by a reviewer, or maybe you're involved in a malpractice case or a state board issue, and you're asked to justify, Dr. Kotler, how did you come up with this diagnosis of sacroiliac sprain? You see, back in the day, when I first started practicing, a patient would come in and say, Dr. Kotler, my back hurts. I have pain radiating into my leg. I just diagnosed sciatica. I didn't do any orthopedic tests. I didn't do any neurological tests. I didn't do anything to help justify it. And I just diagnosed sciatica. And most patients got well, nobody questioned me, and everything seemed to be okay. Well, those days are over. So if you diagnose a patient with sacroiliac sprain and your question, how did you come up with that? This would be a good answer. Well, the patient had pain in the SI joint. Sitting may increase the pain. Lying down may ease the pain. We did Yeomans, Ganslins. You probably remember those names from chiropractic college. Yeomans, Ganslins for Bear Patrick, Eli's. Do a couple of those. I strongly recommend you do a couple of those codes. Now, Yeomans and Ganslins, those are the gold standard tests for sacroiliac joint involvement. See if you don't do that in your question. Oh, so Dr. Kotler, how did you come up with the, sacroiliac joint subluxation or sacroiliac joint sprain strain? And you go, well, the patient had pain and I palpated the area and yeah, it was tender. That's typically not enough. So now if you don't remember how to do Knocklis or Eli's, just go to YouTube. Nowadays it's so easy. Just go to YouTube. You can put in these orthopedic tests. You'll see a whole bunch of quick little short videos to remind you how to do them. And the chiro tests included palpatory tenderness, hypomobility or hypermobility, muscle hypertonicity, Here's another one, back to radiculopathy. So Mrs. Jones comes in and you diagnose her with cervical radiculopathy, and now your question, Dr. Kotler, how did you come up with that? So, well, we did some orthopedic tests, Jackson compression, Valsalva, shoulder depression. We checked reflexes. There was some myotomal weakness, dermatome changes, limited motion. We have an MRI, so that's how you justify it. You want to be able to justify every single CPT code that you submit to a carrier, or if there's a malpractice case, and even a cash patient. Even a cash patient can file a complaint with the state board, right? I've dealt with many of those, helping chiropractors across the country where patients filed complaints against the doctor. And it's typically financial reasons. Like one doctor, the patient wanted their money back. The patient wanted the money back. And the doctor said, I'm not giving you your money back. And then the patient files a complaint with the board. The board asks for the documentation. And they will look at the documentation to see if it's up to par, if it's with the standards of practice. If it's not, this particular doctor didn't have to give the money back to the patient. There was no issue there, but now is in trouble because the documentation was terrible. So you want to have good substantiation. There's a book that I recommend that has a whole bunch of diagnosis codes and the ortho, neuro, chiro tests that help substantiate it. Here's an excerpt. Here's one page out of the book. So, and I do work with some offices, some providers that they're more subluxation based, and they go, Marty, I don't check blood pressure, I don't check reflexes, I don't do any ortho neuro tests. Well, I recommend you do a few. Because if you don't do anything to substantiate your diagnosis codes, you could have problems. So another thing I mentioned earlier is pairing your CPT codes and diagnosis codes. I look at it like food and wine pairing. They're fun. I've been to many food and wine festivals. They're fun, and you learn and how to pair your food with wine, like in general, red meat with red wine and fish with white wine. So here we go. CPT code traction 97012, mechanical traction, pairs beautifully with cervical radiculopathy or lumbar disc degeneration. And then we have therapeutic exercises. That's to increase range of motion and flexibility, strength, endurance. So that code pairs beautifully with sciatica, shoulder stiffness, strained quadriceps. Then we have neuromuscular re-education 97112. Patient has vertigo, dizziness, unsteadiness on feet. Pairs nicely. And then myofascial release, ICD-10 code M79.1. That would pair very nicely with manual therapy 97140. I have one more for you. And these code pairings, they're all in that book I was mentioning to you. So 97530, therapeutic activities, pairs very nicely with M5122, disc disorder with radiculopathy, frozen shoulder, back pain, stenosis. And let me show you a clinical example. This combines diagnosing radiculopathy, some CPT codes, a clinical example, diagnosis pointing, and items on the 1500 form. So a Mary patient comes in, and we deliver a chiropractic adjustment, 1 to 2 regions. You see the CPT code 98940, and then if you look in box 24E, it has the letters A and B. A and B. So A in box 21, that's lumbar disc with radiculopathy, M51.16, and muscle spasm is in B. So I'm doing a chiropractic adjustment to the lower back. And then you look at the next line item, 97140, that's pointing to diagnosis codes C and D. Those are to cervical, that's cervical radiculopathy, M5412. And M79.1 is myofascial pain syndrome. So we're just pointing the manual therapy to those two diagnosis codes. Then we go to electrical stim. Unattended electrical stim is pointing to E and F. What are those two codes? E and F, those are two thoracic diagnosis codes. And then we have therapeutic exercises, which is being done on the lower back. So just wanted to share with you a little clinical example so you could get the full picture there. Alrighty, just a few closing comments. Please check with the carriers you bill prior to submitting claims. based on this information to ensure that it's compliant. Target coding does not guarantee that this information will guarantee payment from any health plan or patient. Target coding is not responsible for any insurance company or managed care organization laws, rules, guidelines that may change following this presentation. And you know they always change, right? So do your best to stay on top of these changes. Attend seminars, attend webinars, join your national and state professional associations. There's our contact information, info@targetcoding.com, website targetcoding.com. Oh, and this is the book I was referring to. The best chiropractic ICD-10 and CPT codes to improve reimbursement. It has the cheat sheets. It has detailed information on how to pair your CPT codes. Here's an example of how to pair your therapeutic exercises with a whole bunch of diagnosis codes in the neck region, and then we also have them for the thoracic and lumbar region. And then we give you the diagnosis codes broken down into long-term treatment diagnosis codes, moderate term, and short-term. So if you choose short-term diagnosis codes, don't expect to get paid for more than 6, 8, 10, 12 visits. Long-term treatment diagnosis codes, now you're looking at, maybe 24 to 30 visits. You should know what they are. And then here's one of the cheat sheets I was referring to, which gives you the long-term, moderate term, short term, quick guide. So you could do a quick check off and give it to your staff members or just enter these right into your system. I mentioned this page out of the book, which gives you the diagnosis codes and then the ortho, neuro, chiro test to support it. We also have a section in this book on frequently asked questions, like what's the difference between spasm and contracture? What's the difference between myalgia, myositis, myofasciitis? What's the difference between effusion, swelling, and edema? How do you diagnose that? So these are common questions that I have received over the years. I put them in the book. Excellent section. Oh, we also offer those of you that see Medicare patients, just a little update. Medicare requires that you have a Medicare policy and procedure compliance manual. Again, if you see Medicare patients, it's mandatory that you have a Medicare policy and procedure manual. So we offer that now with Target Coding, and we've come up with, based on guidance from the federal government, and the Office of Inspector General, we've come up with 18 policies and procedures that would apply to a typical chiropractic practice as far as, how to do your own internal audits, how to look up the exclusions list to see if anybody in your practice has been excluded from treating Medicare patients. So we have that. It's wonderful. It's quick. It's about 35, 40 pages. It doesn't take long to learn how to implement it and make your changes. It includes policies and procedures for your practice, chart audit tools, sample training logs. This is one of the audit tools. It's just a quick checklist to get you going there, to make sure you've entered all the proper information. We also offer HIPAA compliance. Our HIPAA compliance program is top-notch. It's very comprehensive. I don't know any other program that has the comprehensiveness that ours does. You get a 3-ring binder with all your policies and procedures, plus you get everything uploaded to a cloud-based portal. You could go in there and make your changes. It takes about 6 to 8 phone calls with us over a 3-month period to get you HIPAA compliant. HIPAA is not a suggestion, it's mandatory, and you get videos. There's a whole bunch of videos that your staff can watch. We help you track your business associates. It includes $100,000 of cyber liability insurance just in case there's a breach and you need to spend money fixing the breach. This program includes some insurance, so you might want to check it out. We also do tons of seminars. We have a whole bunch of seminars coming up and a bunch of webinars coming up. Some are free, some there's a charge, and some have been approved for CE credits. We also offer memberships at Target Coding. This one is just pay as you go. And then we have a gold membership, which is a 12-month program where we really take a deep dive into your bills, your codes, your SOAP notes, your EOBs, train staff, get you focused to maximize reimbursement. Then we have a platinum membership, which includes an on-site visit to your office. So yeah, here's our contact information, info@targetcoding.com, website targetcoding.com, telephone number 1-800-270-7044. We have a HIPAA secure fax number, so if you're going to fax us patient information, don't worry about whiting out or blacking out the names. If you're going to fax it to our HIPAA secure fax number, there it is, 844-831-2347. Thank everybody for attending. I hope you learned a lot.